So I'm going to go and get started, and I would like to welcome everybody this Friday to this workshop organized by ARO titled Translational Delivery Approaches for Inner Ear Therapies. And this workshop will provide an interactive opportunity to discuss the challenges and opportunity of inner ear delivery technology towards safe and efficacious dosing of emerging therapeutic compounds. We're going to cover different aspects of inner ear delivery, from promising therapeutic strategies to small molecules and cell therapy. We will aim to clarify the translation of delivery approaches used in preclinical animal models to clinical trials in patients. We will discuss on practical aspects, including the experience of local delivery in the middle and inner ear in preclinical models, with a focus on preclinical delivery case studies and challenges for deliveries in humans. And I'm going to co-chair this session with Rami Safiri, and he is an expert in local drug delivery. He received his PhD from the Hebrew University of Jerusalem for his research on biodegradable controlled release devices and their use in the treatment of gingivitis and mammary tumors. He later conducted postdoctoral research on growth factor biology at Harvard MIT Bioengineering Center. And in 2009, Rami joined CBSET, a translational research institute in Lexington, Massachusetts, where he currently serves as the Director of Research and Innovations. Rami, the floor is yours.
Thank you, Peter. Thank you to the panelists, and good morning or good evening to the attendees. Before we start the session, what I wanted to do is really to frame it a bit and understand why we chose these particular speakers and really the topics. And really, anytime you think about drug delivery, the first important thing to understand is that pharmacology is requisite, but not really sufficient. There's a drug delivery aspect to this. And the reason is that you always need to overcome some anatomical and physiological barriers to delivery, and in the inner ear, these are very profound. So in general, the challenges of drug delivery are to deliver the drug to its physiological target or compartment and to minimize off-target delivery and side effects. But getting the drug there is the first step really only. And you also have to retain it long enough to elicit these pharmacological effects, but no longer than this pharmacological requirement, because then you have opportunities for side effects. So coming to the session, we'll review the anatomical and physiological barriers to inner ear drug delivery, and also the preclinical models that are available to us for developing and comparing drug delivery technologies. And in order to contextualize this, we'll have a review of translational case studies presented by the expert panelists that we have here. So with that, it's a pleasure for me to present the first speaker, Dr. Gael Nair from Silcare, who will be speaking about delivery approaches to the inner ear used in animal studies.
Okay, so thank you, Rami, for the kind introduction. It is my great pleasure to participate in this wonderful workshop. I'm delighted to start with the local delivery approaches used in animal models of hearing loss that are routinely used by researchers and at Silcare, and also with the latest advances in these techniques. As you all know, there are some limitations for the route of administration that can be used to target the ear due to its specific anatomy. Like the brain, the ear possesses its own barrier, the blood-labyrinth barrier, limiting the penetration of molecules in the inner ear. To target the ear, there are two main routes of administration: the systemic delivery and the local delivery. The systemic delivery can be by oral gavage, intraperitoneal, intramuscular, or subcutaneous injection. And for the local delivery, I will detail further in a few minutes. With a systemic delivery, the treatment can be rapidly eliminated and side effects can occur. And the drug level in the inner ears is less controlled due to the presence of this blood-labyrinth barrier. With local delivery, which could be in the three parts of the ear, the outer ear, the middle ear, and the inner ear, the level of the drug in the ear is well controlled. The side effects are avoided, and systemic influences and metabolism are limited. Whatever the route of administration, the entry of the drug in the inner ear is limited by diffusion, and the drug is rapidly eliminated from the inner ear. Therefore, repeated administration are required to obtain a long-lasting drug residence in the inner ear. I will start with the first compartment and the delivery in the ear canal. This administration in the ear canal can be performed once or repeatedly, and the volume has to be adapted according to the animal species. Different formulation can be applied on the eardrum, like liquid solution or hydrogel. And this method is highly reproducible, translational, totally non-invasive, and induce none to mild effect on hearing, depending on the tested formulation which is applied on the eardrum. The main disadvantage of this technique is that the site of injection is far from the inner ear. I will now follow with the second compartment and the delivery in the middle ear. As you all know, the most translational method in the transtympanic injection is a transtympanic injection in the middle ear. For this, a stainless needle is inserted through the eardrum in direction to the round window membrane on an anesthetized animal in lateral recumbency. The formulation is delivered close to the round window membrane, and the volume injected is adapted according to the species. And for this, we can use any kind of formulation, liquid formulation or gel formulation. This technique is reproducible, totally translational, slightly invasive. We can perform bilateral injection, and it induces no damage on hearing acuity. However, the transtympanic injection induces a slight injury of the eardrum, which supports limited number of injection in a short period. And also another limitation is the use of liquid formulation, which can be rapidly cleared via the eustachian tube. This is why, this last decade, intensive work has been conducted to optimize the formulation for transtympanic injection. The objective has been to have a sustained retention in the middle ear. And for this, different kinds of formulation have been developed in order to obtain a sustained release in the inner ear. To this end, are considered the physicochemical properties of the drug, the properties of the round window membrane, the parameter enabling accurate drug solubility, and the excipient compatibility for this local delivery method. As mentioned a few minutes ago, the transtympanic injection induces a slight injury on the eardrum. And it has been thought that repeated transtympanic injections can be deleterious for the eardrum, inducing a bias in hearing measurement in animal studies. As the diameter of the needle is very small, we have considered that performing a repeated transtympanic injection is possible if, on each consecutive days of injection, the needle is inserted in the same hole on the eardrum. This is a quite challenging method, but as you can see in this result, it has provided promising results. And in this example, we have performed a transtympanic injection daily for 5 consecutive days in rats. And after a transient increase, the ABR threshold returned to normal values. So we have demonstrated that repeated transtympanic injection is a safe and suitable method to deliver in rodents. And I would like to mention that these data are in accordance with the presentation of this ARO conference by Dr. Scaria, showing that the eardrum is able to rapidly regenerate and demonstrate scare-free repair in mice. Another method for middle ear delivery is the insertion of an ear tube through the eardrum, allowing repeated administration of liquid solution or liquid suspension in the ear canal to enter into the middle ear. Again, the injected volume has to be adapted for species. This technique of tympanostomy is translational, allows repeated administration and reproducible surgery. However, this implantation of the ear tube is quite invasive and consists in an important injury of the eardrum in rodents, resulting in mild to important hearing impairment. And this is due to the size of the eardrum compared to the size of the ear tube, what we can use in a rodent. The drug can also be deposited in the round window niche using a long-lasting formulation, which can be a gel form, an hydrogel, or a thermoreversible gel. This technique consists in the insertion of a needle in the middle ear through the temporal bone using a retroauricular approach called bulostomy to deposit 5 to 10 microliters of a formulation into the round window niche. This technique avoids any injury of the eardrum. Only a single administration is possible, using a long-lasting formulation to obtain a long-lasting delivery. This technique does not affect hearing, and this is really a reproducible surgery. However, this technique is less translational and is quite invasive due to the fact that we have to perform a retroauricular surgery. Using the same retroauricular approach, an intrabular delivery can be performed. And this was published by Lafont and collaborator in 2020 in using a model of guinea pigs in which 70 microliters were injected in the middle ear. So this technique consists in the insertion of a catheter in the middle ear through the temporal bone, directed in front of the round window membrane. This retroauricular approach allows to avoid eardrum injury and any effect on hearing. And the catheter exit site is in the scapular region and is protected by a cap, enabling to perform repeated administration of the liquid formulation. However, to ensure a time of contact between the liquid solution and the round window membrane, as the liquid is rapidly evacuated by the eustachian tube, a daily anesthesia is performed on each consecutive days of administration. In this publication, no pharmacokinetic data was reported, but it would have been informative. And we know that this surgical approach is reproducible. However, this is not translational, quite invasive, and the drug retention in the middle ear cannot be controlled. As I mentioned, only liquid formulation can be used and will be rapidly cleared via the eustachian tube. At Silcare, we have developed a similar technique using the same surgical approach. In fact, it is possible to connect the catheter exit to an osmotic pump, which will be placed in the intrascapular space, to have a continuous infusion on the round window membrane. And this in order to enhance drug retention in the cochlea. For this, the rate of the infusion and the duration of the infusion are defined by the pump selection. We can be Alzate osmotic pump or other kind of osmotic pump. Compared to the previous method, the continuous infusion should allow a higher cochlear drugs level. And in addition, at Silcare, we have performed a comparative studies using this intrabular infusion this continuous intradural infusion, compared to repeated transtympanic injection. And the PK results, the pharmacokinetics results, showed the highest cochlear drugs level with intrabular infusion. However, this method induced important variability in cochlear drugs level due to the clearance of the formulation via the eustachian tube. Here is a list of therapeutics that have been developed for middle ear delivery and have been or are currently in clinical trials. As you can see, different formulations have been developed, all aiming at long-lasting delivery and for different indications like tinnitus, sensorineural hearing loss, or cisplatin-induced hearing loss. Now, I will describe the route of administration to deliver in the third compartment of the ear, the delivery in the inner ear. In preclinical research, direct delivery into the cochlea is used to deliver a liquid formulation of small molecules or bigger proteins, and more importantly, gene and cell therapies. For this, three-main surgical approaches are available for intracochlear delivery: an injection, a single injection in the post-semicircular canal, avoiding any effect on hearing, an injection through the round window membrane, and finally, a cochleostomy administration via a small hole at the base of the cochlea. For this cochleostomy, both single injection or continuous infusion using an osmotic pump are possible. These two last techniques, so the round window injection and the cochleostomy administration, induce slight to mild hearing impairment. And in addition to this intracochlear delivery, I would like to mention an innovative approach to mimic the intracochlear delivery. Jing Wang from the group of Jean-Luc Puel is presenting a poster demonstrating that intrathecal injection in the cisterna magna, which is usually used to sample CSF, enables to deliver AAV simultaneously in the left and right cochleae in mice. On this slide are shown the number of studies conducted in humans and in animals, using the different route of administration for middle ear delivery and for inner ear delivery. I'm not going to go into too much detail on this table, as one of the next speakers, Ronald, will do it better than me. I only would like to mention that some of the inner ear delivery techniques have already been used in clinical trials in humans. So to conclude, the take-home messages of this presentation are: for preclinical research, different methods for local delivery are available for rodents, and this in the three compartments of the ear: the external ear, the middle ear, and the inner ear. These techniques allow single, repeated, or continuous administration. They have different degrees of invasiveness. They induce known, slight, or mild hearing impairments. And they allow the administration of different kinds of formulation and different kinds of products. They are not all translational, but are great tools for investigational research and enables to test and validate therapeutics in development before clinic trials. So thank you for listening, and I will be pleased to answer your question if you have any.
When there's middle ear delivery of a compound, particularly not in a gel formation, how long would you like the subject to lie supine before becoming ambulant, before they can start walking around again when they recover from the injection?
Can you just repeat the question? Sorry, Peter.
How long would you like the liquid delivery on the round window or the round window niche to lie there, or the mouse or the rat to lie there before they get up and walk about? Because that will obviously increase the clearance rate if they start moving.
So usually when we inject a liquid solution by in the middle ear, in fact, usually we do not observe we do not observe drug residence after 24 hours in the ear. So usually we suggest to do repeated administration in this case. And for some compounds, so it really depends on the properties of the drugs itself, which if it is able to cross rapidly and robustly the round window membrane.
Thank you. And we have a question in the chat from Antoine Hurt. Dear Gail, thank you for this nice overview. How can you control with those different approaches to avoid the vestibule?
So for the middle ear delivery, we do not believe to target the vestibule part, because we observe the gradient of the drug from the base to the apex of the cochlea, and it's true for local delivery, we will reach obviously the vestibule as well, because if we inject via the PSCC, the post-semicircular canal, we will target the vestibule.
Right. Yes, that's right. I think you know, in clinical applications right now, if we give gentamicin via the round window, it's typically used to kill sensory hair cells in the vestibular system. Is that mainly because of leakage into the inner ear via the oval window? And if you can localize it to just the round window, it's much harder to cause toxicity in the vestibule?
Yeah, so it's true. You're right. When we deposit gentamicin on the round window niche, it has an effect on the cells of the vestibule. But to be clear, we only at Silcare we only work on the cochlea. We never assess what occurs in the vestibule. So I cannot clearly answer this question.
Okay, very good. We have some more questions, and we have a little time till 10:30 before I introduce the next speaker. So John Brigandi writes, is there a pharmacological strategy to temporarily restrict or narrow the eustachian tube in an effort to retain the drug in the middle ear for longer durations?
No, with liquid formulation, we cannot avoid this clearance of the liquid formulation via the eustachian tube. The only things we can do is to increase the time of contact between the drugs, the formulation, and the round window membrane. So for this, when we perform transtympanic injection, for example, we will increase the time of anesthesia, keeping the animal on its lateral side. It can increase the diffusion of the drug in the cochlea.
Okay,
But
great.
Yeah.
And Regina writes, what would be a strategy to try and have a less invasive method to deliver drugs to the inner ear?
So the transtympanic injection is not really an invasive method. This is we would just perform a small hole on the eardrum, and it's routinely performed by a INT surgeon. So this is not invasive. But for the other techniques using surgical surgical approaches, it will be difficult to avoid this invasiveness. And this is why I have mentioned the poster of Jingwang, because injecting in the cisterna magna is something very easy to do. So, and it's not so invasive, and I think it's more translational for human.
Okay, so just to follow up that question very quickly, when you do a transtympanic membrane injection, how long does the perforation by the needle, how long does that perforation take to heal in the tympanic membrane?
So 24 hours after the single transtympanic injection, we already see the healing of the eardrum, and we do not observe 5 days and 7 days after any effect on the ABR. So we consider that 24 hours after is the healing.
Great.
Yeah.
And this segues into the last question that I'm going to ask you this morning before the panel session at the end. Do any of these delivery methods affect DPOAEs?
Yeah, so injecting directly at the base of the cochlea will have an effect on DPOAE and ABR, as we will for some we will modify the outer cells. So yeah, but for the transtympanic injection and the intrabular injection of all the delivery in the middle ear, we have no effect on ABR and DPOAE.
Okay, fantastic, great. Thanks for a great presentation and introduction for those of us coming to this field from other disciplines. Thank you, Gail, it's fantastic. We will see you near the end.
Thank you.
With that, I'd like to introduce the next speaker, Bonnie Jakes. She's from Autonomy in San Diego, California, and she will be presenting today on factors in intratympanic drug delivery for the inner ear. Bonnie, the microphone is yours.
So thank you so much to Gael for the lovely introduction to intratympanic drug delivery. So what I'm going to talk about for you today is some examples of how we've used intratympanic formulations to optimize drug delivery for several products in development at Autonomy. And so Gael nicely walked us through sort of some of the considerations around intratympanic delivery or transtympanic delivery. And we've known that ENTs have used this delivery method for many years to inject particularly steroids in the ear for Meniere's disease and other conditions. However, a lot of these off-the-shelf formulations are liquid, and as Gail mentioned, they clear out really easily. So you get very little residence time, and so minimal efficacy. And so what Autonomy has been working on for over 12 years is a way to optimize formulation technologies so that you get better residence time in the middle ear and ultimately better efficacy. And so I'm going to use two different examples from our pipeline, Oto 313, which is a small molecule for tinnitus, and Oto 413, which is a biologic for hearing loss, and kind of help walk through case examples of how we've optimized formulations and or used preclinical models to drive data that would lead us ultimately to clinical trials. And so again, just kind of highlighting some of the considerations when you want to optimize an intratympanic drug formulation, you really want to look at some of the physiochemical properties of your drug. You can't just use any generic off-the-shelf excipient to try to optimize that. You really have to look at how your drug product's going to interact with your vehicle. And so looking at excipient compatibility. You also want to, one of the big issues is the duration of exposure. You know, what is the condition you're trying to treat? A lot of times for the otic conditions, they're chronic conditions. And so you would probably want to have an extended duration of drug in the ear. And so also where within the ear are you getting that drug? And so these are some of the aspects that I'll talk about, but these are all critical factors when designing a drug or studies, as you want to be able to maximize all of these to match your disease condition. And so again, you know, when you're looking at what would an optimal formulation look like, you should be able to get ideally weeks of drug exposure from a single IT injection to avoid the risks of the repeat injection. Repeat injections on the acute scale over a couple of days, you know, you're required to go through the same injection hole. But if you can deliver drugs every few months or more, you know, the eardrum will heal up completely and it'll give you a nice surface to re-deliver. You also want to look at the drug levels throughout the ear from the base to the gradient. When you're generally delivering as an intratympanic drug, you're targeting the round window, so you'll expect to see higher levels at the base initially, but having a longer residence time will let that drug flow all the way through the apex and give you nice uniform exposure. And then what's also critical to think about is your middle ear findings. You're going to get a much higher concentration of drug in your middle ear than is actually going to diffuse into the cochlea. And so you have to make sure that both your vehicle as well as your drug product are safe within the middle ear, and you can often find irritations there. And so that's a big factor when you're designing your drug. And then there's just basic things about drug development, like you also want it to be easy to prepare and use. You're going to be injecting it in a small, delicate ear, and so it has to be syringeable and easy for a physician to administer, and then other basic things about being balanced, pH balanced for the ear. So kind of using these strategies, Autonomy has developed a really broad pipeline focused on hearing loss as well as tinnitus. You can see here we have multiple programs covering things from cisplatin-induced hearing loss, severe hearing loss, as well as congenital hearing loss. But what I'm going to focus on today is just two of our programs that are currently in clinical development. Oto 313 is gacyclidine, which is an NMDA receptor antagonist for tinnitus. And Oto 413 is a biologic protein of BDNF that's developed for hearing loss, in particular speech and noise hearing difficulties. Both of these have undergone phase 1-2 trials, and we saw really positive results in the safety. We saw no safety considerations there. And in the phase 2 portion of the trials, we actually saw nice efficacy signals in patients. And I'll talk about some of that data in a little bit. But so these, I think, are good case examples taking from preclinical development all the way through the clinic. And so here's just some example of data from dexamethasone or steroid injections comparing a dexamethasone solution in purple to a IT formulation in blue. And what you can see here is this is the pharmacokinetic profile in the perilymph of the cochlea when sampled. And you can see that with a solution, we get pretty decent levels early on, but within less than a day, we're already losing drug levels completely in the cochlea that can't be detected. However, if you formulate dexamethasone in an otic long duration exposure type of formulation, you can see that we get really nice out to multiple weeks of exposure and significantly higher levels initially, suggesting that we could have potentially better efficacy with a drug profile like this. Similarly, if you look at the distribution throughout the ear compartment with the solution formula, while you're getting high levels in the base, it drops off significantly as you move up the cochlea with very little drug exposure in the apex. However, then when you look at a formulated for the sustained release formulation, you can see you get really nice uniform levels throughout. And so this just kind of demonstrates the need for this type of otic specific formulation. And so you might be asking, if you can develop these type of drug levels, how well are these type of results then going to be able to translate into the clinic? And so you want to look at both efficacy, how would your efficacy models in preclinical development translate, as well as your pharmacokinetic profiles. And so I'll walk you through examples showing how efficacy studies from animal models can indeed kind of predict what you will see in the clinic from examples from both Oto 413 and 313. But also, with the PK profiles, there's only so much we can actually measure in humans, right? Typically sampling in the inner ear is only done in humans in very rare circumstances during surgery or inner ear removal or cochlear implantation. And so we have limited opportunities to look at that. However, we do know that there's very minimal systemic exposure in terms of blood plasma levels in both humans and animal models, suggesting you get a really nice correlation there. So Bird et al. Were actually some of the first ones in 2007 to be able to measure human perilymph drug levels in patients. And they did this by pre-administering steroids, either by an intratympanic delivery or IV administration. And then at the time of cochlear implantation, they actually were able to sample some of the perilymph from the round window. And what they found was that they got a 200-fold higher level of drug within the cochlear perilymph compared to IV delivery. And in the plasma, you see almost a 40-fold lower exposure systemically than from the IV. So this really kind of matches what I showed you in the guinea pig data earlier, is that the need and the benefit of an intratympanic delivery is really critical. But however, if you look at the total concentration, it's not that high. And so there must be some way, because these were delivered as a solution, not as a sustained formulation. So how do we improve that? And what the study concluded was that you can get higher paralymph drug levels when you get higher residence time with the round window membrane. And so Autonomy was working on figuring out, how do we develop technologies that would enable us to have drug there longer. And so the first example I'm going to talk through is how we optimize the formulation is for OTO-313, which is gacyclidine for tinnitus. And so most of us know that tinnitus is caused by injury to the cochlea from noise, trauma, ear infections, ototoxins, as well as some genetic causes. And NMDA receptor antagonists have been used for many years to show modulation of neural activity, in particular in the ear. MK801 or ketamine have been shown to impact tinnitus. What was found is that gacyclidine was shown to be an even more potent and selective NMDA receptor antagonist than either MK801 or ketamine. And when local administration was compared between gacyclidine in a liquid formulation versus these others in a salicylate model of tinnitus in guinea pigs, we actually got really nice efficacy with the gacyclidine. And the study was published in 2003. And interestingly, gacyclidine then was used in a proof of concept trial for compassionate use in humans. So there was actually some initial clinical data. It was an open label study suggesting that with a liquid formulation of gacyclidine, you could get some benefit to tinnitus patients. And so Autonomy took over gacyclidine as a lead molecule and decided to try to figure out how we can generate better efficacy in humans and create better technology around this drug. And so here I'm showing you some initial formulation data from OTO-313. Our initial formulation was called OTO-311, and it was gacyclidine and a poloxamer P407. And you can see here the paralymph levels in poloxamer formulation were actually quite low, and we had very few days of exposure. And so this was not an ideal PK profile. And so we went back to the chemistry, and in looking at gacyclidine, which is a very hydrophobic molecule, it seemed to make sense then to, rather than a liquid formulation, it made more sense to complex it in a lipid-based vehicle. And so when we went back to then a lipid-based formulation shown in blue, you can see we get much higher drug levels initially, and these are sustained for a much longer period of time. So we got greater Cmax, duration of exposure, and area under the curve. So the takeaway here is that really when you're formulating, you can't just pick any off-the-shelf vehicle. You really should target it to what your drug is. So we did additional formulation work to come up then with our final formulation called OTO-313, which then gives us this nice sustained product profile in this lipid formulation. And so you can see here in the paralymph, we get nice high drug levels, and they're sustained throughout multiple weeks. However, it's really interesting at Autonomy, we also kind of pioneered an approach of looking at drug levels within the tissue itself. So while we're getting good drug levels in the paralymph, our actual target tissue are the neurons and the tissues of the cochlea, and not necessarily just the fluids. And so if we collect the tissue and then measure drug levels, you can see in the cochlear epithelium, we actually get even higher drug levels initially, and they're sustained for really nice periods of time. And so I think this kind of illustrates how it's critical to not only look at the solutions, but also to look at your target tissue and see what the drug levels are there. And so with this, we thought we had a really nice target profile and understanding of drug levels in the tissue to then drive a clinical trial. And we had no safety concerns in the animal studies that were run, good middle ear and inner ear findings. So we conducted the first proof of concept trial using OTO-313. It was a randomized, double-blinded, placebo-controlled safety and exploratory study. We did screening for tinnitus in a lead-in period. We then gave one dose of the OTO-313, and then we had an 8-week follow-up where we looked at the tinnitus functional index, which is a patient-reported survey of how their tinnitus affects their lives at day 15, 29, and 57. So all of our patients had unilateral and persistent tinnitus. And we also had them record tinnitus, loudness, and annoyance inventory every day using a phone diary. And what's really nice about our drug formulation is it allowed us to look at days as late as 29 and 57 post-injection because of the residence time that we would achieve with this formulation. And so here's just some initial findings from our efficacy portion of the study. We had no safety concerns with our dose levels. And so when we looked at patients across this, we could see really clear responders to the ODO 313. So here is shown as the percentage of patients with TFI improvement. And we define a clinically meaningful improvement as a 13 points or more on the TFI test. And what you can see is we had more than 40% of patients scoring greater than 15 points, and as many as 20% or more even scored greater than 30 points. So really clinically meaningful benefit from this drug. And so that's really promising as a potential to use this as a therapeutic one day. So I think this kind of nicely illustrates how by using the right formulation and delivering it with the right properties throughout the ear, you can see this clinical benefit. So the next drug I'm going to talk about that's in development here is ODO 413, which is BDNF for hearing loss. And so BDNF is a member of the neurotrophic factors, which are well known to play important roles during development as well as adulthood in synaptogenesis, neuron survival, branching, neurite outgrowth, etc. And there's nice data from the field on the use of neurotrophins to promote neuron growth in the cochlea. One of the more recent topics, or pathologies that have been noticed is the synaptopathic hearing loss, which is sort of the early onset of age-induced hearing loss, where you first get degeneration of the synapses. And so we thought, given the effects of neurotrophins, could this be used as a treatment for the speech and noise hearing deficits that are associated with the synaptopathy? And so we did some formulations in-house of various different neurotrophins and related molecules and found BDNF to be the top performer. And so BDNF, being a protein biologic, was nicely compatible with paloxamer 407. And so when we look at the PK profile of this, you can see that in both the cochlea and the perilymph, we get really nice high drug levels when delivered in, this is data from a rat, and then we get sustained drug levels out to 28 days or more, and in particular, nice high levels in the cochlear epithelium itself, where our target would be the synapses around the inner hair cells. And so this just demonstrates that ODO 413 is able to give us really nice exposure when complex in the proper formulation. And this data we've seen now in multiple different species in animal models. And so the next part was looking at the efficacy of this formulation. And so we chose a rat model of noise-induced hearing loss, which was mild synaptopathic hearing loss with some ABR changes. And what you can see here is when we actually look at the synapses in these rats, measuring the pre and post synaptic puncta, you can see that we get a really nice increase in the number of puncta compared to noise only and vehicle exposed animals. So the 413 is really driving a nice improvement in the number of synapses, very consistent with the levels seen even in naive animals. And then to look to see if this type of change would actually translate to a functional improvement or meaningful improvement. We looked at the ABRs, and we did see, in addition to seeing gross improvements in the ABR thresholds, we noticed that across all frequencies, we also saw a really significant improvement in wave 1 amplitudes, which are a measure of synaptic output. And so this nicely demonstrates that with the formulation, we can get good drug levels as well as morphological and functional improvement. Safety studies in animals then showed no issues. And so we moved on to an IND and clinical studies for this drug. And so in our first proof of concept trial, we conducted a phase 1/2 ascending dose safety and exploratory study. We did baseline screening and testing of the patients, and these were done in patients with speech and noise hearing difficulties, as well as moderate hearing loss by audiometry. Then we performed a single IT injection and then followed them out for several weeks and out to 85 days, the longest time points. With the safety arm of this, we found that ODA-413 was well tolerated across all dose cohorts. So we had no concerns there. And so we were able to evaluate the efficacy in the 10 patients with the highest, that received the highest dose compared to placebo patients. What we're really happy to see was that ODA-413 actually showed some therapeutic benefit in these patients. We had a higher proportion of patients that showed a meaningful benefit on multiple speech and noise tests at both day 57 and 85, which is nice because, again, we are able to look at these longer time points given the delivery technology. And we define clinically meaningful improvement as greater or than 20% improvement from baseline. So here's just a little snapshot of the data from the clinical trial, and you can see in the placebo that the majority of patients across all days on all 3 of the tests, so we perform, here's showing 3 of the speech and noise tests, American English Matrix, word and noise, or digits and noise. You can see most of them had either no change or worsening of their tinnitus. Or if you look at the ODA-413 treated group, you can see that many patients actually showed benefit and improvement on these tests at both day 57 and 85, demonstrating not only can we see improvement, but we can see improvement for several months out, which is really nice. And so this also then demonstrates that if you have the right animal models and the right formulation, you can also then translate that to a really nice clinical benefit, as we saw in the animal models. So just to wrap up, I think what between what Gael presented earlier and what I've shown here, we can see that local delivery of a drug via intratympanic injection is a safe option and an effective way to deliver drugs to the inner ear. You get really nice drug levels in the ear, and by targeting your drug and its formulation and excipient to the actual disease condition that you're trying to treat, you can get optimal formulations and efficacy. Also, you want to make careful study design and selection of your appropriate in vivo models that will help you understand how this might translate to the clinic. And here I've shown you examples from both 313 for tinnitus and ODA-413 for hearing loss, that using this type of strategy, you can get nice proof of concept data in the clinic. And so right now, Autonomy is continuing to work on our proprietary drug delivery technologies as they're applicable to a range of therapeutic agents and potential other disease indications. Thank you very much. And with that, I will open it up to any questions.
Thank you, Bonnie. Peter, maybe while you compile, the list of questions, I had a quick question for Bonnie. I'm interested, you made a point of walking through how preclinical studies can predict the clinical clinical results. And I'm wondering, how does that impact, like with the consideration of choosing the animal models, the specific species, for example?
Yeah, so I think the choice of species is really dependent on what disease model you want to use. I think there's, for some indications, the mouse models, especially if you're looking at a genetic mutant, or you can mimic that, you might want to select a mouse model because that could be your efficacy model. In terms of PK, I think rats and guinea pigs have commonly been used, and there's some other species that can also be used as well, but it's really matching that to what your best I think disease model is, and so that really will vary just depending. I think for noise-induced hearing loss, rats or mice are good models. I think rats are a little bit easier to deliver in, especially for IT, because you have more space and they're significantly bigger, and they're very easy to do studies on. So it's really just kind of balancing what your needs are around that.
Thank you.
Okay, so we have a few questions here. Very briefly, we'll go through those. So the first one is from Pierre Gorstrup. ODA-413 would be expected to have diffusion-dependent release from the poloxamer. How does that compare to residence time for poloxamer in the middle ear? Will you have an empty poloxamer shell lasting longer than drug release?
Yeah, so what's interesting is when you deliver drugs in a poloxamer, the poloxamer actually acts as more of a carrier. And so you'll see the poloxamer, if you look several hours or up to a few days after a poloxamer-based drug delivery, you'll still see signs of the gel present, but it is a very soluble product. And so eventually that poloxamer disappears and leaves behind sort of a depot of drug. And so we've seen this kind of describe it with a dexamethasone, which is a white particulate-based drug product, that you can see actual white substrate in the middle ear compartment for even a month or two out after all the poloxamer has gone away. So we don't think that the poloxamer acts as a shell, and actually that will disappear and sort of leave a depot of your drug product behind.
Interesting. Our next question is from John Brigandi. For both drug formulations, does serial administration in animal models lead to enhanced drug retention in the sensory epithelium compared to levels achieved in the sensory epithelium by a single injection?
Yeah, so I think that's interesting, and that really, the results would depend on the type of vehicle that's used. And so I know there's some strategies where you're dosing a solution and you dose, every day for several days versus a single injection. And oftentimes those will fail to achieve that duration of exposure. So you might get high comparable levels from those daily injections, but then when you look even a week or two later without a nice sustained release formulation, you're gonna lose that durability of exposure. And so I think that's kind of critical in thinking about what time course you would like to see your drug acting over. But if I think it wouldn't be feasible to deliver the gel multiple days in a row, because you're still going to have gel from the pre-existing injections there. So I think if you're looking at a multiple delivery strategy, you would want it to be a solution. But again, you're not going to probably achieve the PK profiles that you would with a system formulation.
So just following on from that question, I posed the question, is autonomy able to localize the drug that's being delivered, in this case BDNF, in the cochlear epithelium, and if so, is there a base to apex gradient?
Yeah, so in the epithelium itself, we've seen really nice exposure. And I think one way to look at where you're getting the actual drug to the cochlea is you can look at some of the pharmacodynamic effects. So looking at what some of the downstream signaling pathways are. In some cases, you could, tag your drug with either a radio labeled tag or a fluorescent tag. So there's multiple ways that you could look at that. In our case, I think there's really nice literature and data that's out there on getting the drug throughout the cochlea with a poloxamer-based formulation.
Great. So Chris Lanting writes, the preclinical data did show changes in ABR wave 1. How does that translate to humans? Was it part of the set of outcome measures for OTO 413? Mm-hmm.
Yeah, so typically in humans, I think most people consider, rather than wave 1 as seen in rodents, wave 4 and 5 may be a more predictive measure of synaptic strength. In our study, we primarily focused on the speech and noise tests as our critical endpoint, because those I think are the most meaningful, because that's actually showing how does the patient function in the real world and what type of benefit are they seeing. So that's why we focused on those speech and noise endpoints, because it's going to translate exactly to how it's improving the patient's hearing.
Fantastic. Two more quick questions and then we'll move on. This is from Gregory Robinson. For cochlear delivery with your otic formulations, what is the molecular weight limitation of molecules?
Yeah, so that's what's really interesting about the strategy is you don't really have a limitation. We have seen that, I think that your main limitation is what can the round window membrane itself transport. And I think the round window membrane is able to have active transport, passive transport, penocytosis. There's multiple mechanisms. So, we've seen everything from viruses to large molecules, proteins, antibodies, nucleic acids can get through. So it doesn't seem like you have a major limitation in the size of your drug. It's just finding the right compatibility with your excipient.
That's fascinating for me in particular. And so the last question for you at this time is from Shrestha Dash. Poloxamer forms a hydrogel. So how would it form a gel in the middle ear, or what is the mechanism of gel formation? And how long would it remain in the middle ear once it forms a gel and starts releasing the drug?
Yeah, so poloxamer is a really interesting thermal reversible polymer, and it also has multiple phases. So when it's cold, it's a liquid, and almost instantaneously upon touching a 37-degree substrate, it will start to gel, and it gels really fast. You can put a drop of the liquid on your hand, basically turn your hand upside down, and that gel will hold there. And so what's really nice is that it's, you know, a liquid when you're actually delivering it, so it's easy to administer. And then once it sits there, you've got several days at least of the poloxamer just sitting there acting as a gel. You know, it is a fluid compartment in the middle ear. It's not fluid filled, but there is fluid present. And so you will get clearance eventually, but you can expect to get at least several days of your poloxamer residing there and holding your drug in place.
Okay. Thank you. So Rami, the microphone is yours.
Thank you. So we'll be moving now from a great talk about the middle ear and delivery to that compartment to delivery to the inner ear in humans. We'll be hearing from Dr. Ronald Pennings from Radboud University Medical Center.
Okay, so today I'm going to speak about the approaches for optimized local delivery of inner ear adenovirus AAV gene therapies in preclinical studies. So that will be a talk dedicated to gene therapy. All right, so that in this slide, I would like to touch upon the main models that are used for gene therapy. People have used Drosophila and zebrafish because they present hearing systems and anatomy which are simplified, but they are useful for screening for autoprotectants, but also to initiate regenerative strategies by gene therapy. Then we have the mice models, which are strains are useful to recreate pathological models and also to functionally study mutations found in human, provide proof of concept data and efficacy data. In mice, what is interesting to keep in mind is that there is a cutoff from P20 where the mice hearing system matures. So it's creating during translational studies differences in development between mice and human that impacts the translational studies. Because if we transpose therapeutic intervention at P20 in mice, that would correspond to in utero intervention in human. And intervention in mice after P20 would correspond to postnatal intervention in human. And this is where we are heading easily. Then we have the guinea pig model, which is not deaf at birth. This is an interesting model for surgery because it's a large animal, and also for efficacy data, and has been used for inducing regeneration, for example, through gene therapy. And finally, non-human primates. These are translational models used as mice for optimizing surgeries, assess the route of administration intended in human, and conduct IND-enabling studies. So this model presents similarities with human in terms of anatomy, but also progressive hearing damage, physiological processes, and phenotypes which are associated with human disorders. And it's also interesting because it's a model where we can look at the immune response to AAV vectors. All right. On this slide, I'm showing the gene expression profile of the most prevalent deafness genes. As we can see, these genes like GTB2, pendrin, stereocylin, alpha-tectorin, these genes concern a number of different cells, hair cells, but also strial cells, supporting cells, and that are basically concerned by these disorders that can be treated by gene therapy. And the cochlea is a mosaic of these different cell types, and therefore it will be necessary to tailor the AAV-mediated gene therapy approach to the right target cells. For the inner ear, we have a favorable anatomy and biology for the development of the gene therapy approach because it's an enclosed compartment which allows for local targeted delivery. We have a few target cells as opposed to a global organ or global gene therapy. So there is a small volume that needs to be delivered, meaning a limited quantity of vector needed for meaningful transgene expression. Generally, the cells are post-mitotic, so this allows for one-time delivery, lifelong expression, and long-term therapeutic effect. The cochlea is also under reduced immune surveillance, so there is a lower impact of neutralizing antibodies against your AAV. And the anatomy is fully developed at birth, so meaning that the pediatric population can be targeted with a favorable benefit-risk profile. And we can also count on established otic surgery approaches that can support the delivery to humans, such as the one for cochlear implantation or stapedotomy. For gene therapy approaches, we have a diversity of vehicles, non-viral and viral. I'm going to touch upon the viral ones briefly. So first, lentiviruses. So these are lentivirus are able to transduce non-dividing cells. They have been anyhow not really useful to transduce hair cells. Then we have adenoviruses, and these mainly concern 82 and 85 serotypes, and these have been linked to the immune reactions. So this is not still a technology of choice. And regarding adeno-associated viruses, they are considered as being the delivery system of choice for gene therapy because they don't present such issues. The adenoviruses are a member of the parvofamily viruses. They have 12 serotypes identified in human, more than 100 in the non-human primates. And interestingly, it is possible to formulate AAVs with exosomes, which are 30 to 90 nanometer cellular vesicles. And we can formulate that with AAV being present inside and the surface of these exosomes. And in this case, it has been shown that the exo-AAV technology outperforms AAV in terms of transduction efficiency for hair cells, in vitro, ex vivo, but also in vivo. AAV vectors are really interesting vectors for gene therapy in the inner ear. They provide effective transgene delivery with favorable safety. They target a wide range of inner hair cell types, as mentioned before. They're replication deficient. They are not associated with non-pathology. They provide a long transient expression. Generally speaking, they are associated with weak innate immune response, and low level of pre-existing immunity can impact the efficacy of the virus. We have a variety of serotypes with variable tropism, which can target the relevant cell types, and we can optimize that. We can also use ubiquitous and cell-specific promoters and further design them in order to achieve the envisioned selectivity. And no wonder now that this is a common vector for gene transfer in clinical trials, with more than 200 trials that have been using or are using an AAV vector so far. The main disadvantage, though, is the limited packaging capacity, which is 4.8 kilobase. It means that when your transgene is exceeding this capacity, you are to find another strategy. One of the strategy would be to use a dual vector technology, meaning that you would split your gene of interest into two parts and put each of the sequence into a single vector, combine these two vectors, and co-transduce the cells with these dual vectors. And then upon recombination, the full-length sequence will be reconstituted and the full-length protein will be produced. Then you can do the other way. You can try to reduce the size of your transgene, but it's really difficult to find reduced or mini proteins which retain the full activity of the wild type one. Another approach could be overloaded AAVs, and in this case, it's exceeding the packaging capacity, and it has strong implications in terms of further development related to industrialization and up to the commercialization stage through the CMC activities. And we are now entering interesting years because several AAV gene therapy programs are nearing the clinic. If we take, for example, otophalin deficiencies, like DFNB9 hearing loss, 3 programs are approaching the clinic, including Sensorians. And on this program, we had a poster at the ARO meeting, a poster 650, and you can still see it on the website of Sensorion. Right. So this is an attempt to map the tropism of the EV vectors available to the target cells. The difficulty is to get a coherent pictures of the studies because they differ in terms of age of the model, the species used, administration mode, but also the timing post-injection where the analysis was performed. But anyhow, we can see that roughly about 90% of the capsid that are used now will target hair cells. The AAV mainly we target inner hair cells and outer hair cells, as well as spiral ganglion cells and supporting cells are usually transduced with a lower efficacy. In this context, some AAVs have been modified to increase transduction efficiency or change the tropism for different cell types. For example, on the left picture, we have an AAV2, which can be modified to introduce point mutations. So variant AAV, for example, changing tyrosine residues to prevent proteasome-mediated degradation. We can also perform pseudotyping of the vector by changing the helper plasmid and the cap protein. We can have a vector with a different capsid. We can engineer the DNA through DNA shuffling, like it was done from AAV2 to create the vector AAV-DJ, which has a much better transduction efficiency for hair cells, and further increase that by, for example, inducing cell-penetrating peptide to create AAV-AE, AE for inner ear, which has also a much better transduction efficiency for inner hair cells. So now speaking about the challenge to introduce the gene therapy to the cochlea. So previous speakers have spoken a little bit about the main approaches. So they are direct, indirect, cochlear, vestibular, or through the inner ear, for example. Each of these methods are pro and cons. The surgery and injection method need to be adapted to the target cell population and the indication. So going back to an injection through the intravenous, for example, this is something which is not really envisioned in the field of gene therapy because of the unwanted side effect of target expression, systemic exposure, and also lower efficacy to reach the target cells in the inner ear via the BLB. At the bottom of this table, transtympanic approach, as discussed previously, is routinely used, is minimally invasive, but the thing is that currently available IV vectors are not payable to the window membrane, so we need to find alternatives to bypass that. And also, we could have a good amount of loss of the therapeutic agent via the eustachian tube. So the main methods actually for gene therapy in the inner ear are through the round window, through cochleostomy, and through canalostomy. Okay, so this is an example of the surgical setup that we have at Sensorion. We use microinjectors. The injections are made under BSL2 safety cabinets through canalostomy or window membrane injection. And after, say, 15 days after the injection of an AAV vector, such as an AAV driving GFP expression under the control of the CNV promoter, you have nice expression of the GFP in hair cells. All right. So going back to the three main surgical approach for gene therapy, we're going to start with the canalostomy. Canalostomy is an injection in the vestibular system. Weight change group has shown that the delivery to the posterior semicircular canal results in great transient expression in mice throughout the length of the cochlea. There is more transduction at the apex and less at the base. The method is very efficient at P0, P2 in mice, and it's more difficult in more mature mice. And also in human, canalostomy is difficult to access, and therefore it is less known to otologists. So we want to project ourselves toward the clinic. So we and many groups prefer to establish surgical access points to the inner ear that are more familiar to otologists. So it has been shown that injection through the round window or the oval window is associated with good safety in NHP and mice. Round window membrane injection allows to transduce up to the apex. However, it is common to see base to apex gradients of transduction efficacy in mature mice, and sometimes you have the opposite in younger mice. Then various groups have also shown that the double fenestration, be it through the oval window as shown on the top and on the lateral canal, can greatly permit longitudinal fluid distribution of the vector, even distribution of the injected vector along the cochlear length, allowing better distribution of the AV vector, limiting gradients, and increasing the efficiency of transduction overall. In this case, in this example, we are showing a round window membrane injection in mice of an AAV CMV GFP vector at P14, and we are looking at the outcome of this injection, 15 days post-injection, by staining with actin, myosin 7A, and GFP. And what we see is that we have a good transduction overall, but the transduction is much higher at the apex and much less at the base, which is the region where the injection site was created. We also see that the vestibular system transduction is less good in this paradigm. So the technique would not be favorable to treat Usher, for example. The downside of this injection is that gradients are observed, and we cannot overcome these gradients without increasing injection volume. But if we increase injection volume, we are going to impact quickly hearing. So the system is closed, so we could be meeting fluid resistance and have backflow of the product out through the round window membrane where the injection was made. So moving to the round window approach plus a double fenestration, people have shown that if we perform this double fenestration, we can overcome this flow resistance and possible backflow. This is an example of an NHP injected on the top with under round window injection only, on the bottom with the double fenestration, the same AV and the same titer was injected. And what we see is that there is much greater transduction efficiency under the double fenestration approach. This is highly dependent on the volume, the flow rate, the titer, and the injection device used. But it indicates that if we meet this flow resistance and volume escalation, that can be a problem, but that can be overcome through this strategy. The limitation of this strategy is that it's a more invasive surgery, and that by increasing the volume to meet a good transduction rate across the whole tonotopic axis of the cochlea, we could potentially generate a fluid replacement, the cochlear fluids replacement. Sorry. On this slide, I'm showing the summary of the challenge in preclinical models. So the pictures show the same AV vector injected in mice on the left and in non-human primates on the right. And we see the tropism of the same vector is different in mice. It's mostly in inner hair cells, and in non-human primates, it's inner hair cells, supporting cells, outer circular cells. So what we are meeting is a different tropism and transduction rates. We are also meeting gradients, a variable across inner ear, across maturation stage and species. We're also facing morphological differences across the species, so the surgery needs to be adapted each time. And the surgery route can alter the overall biodistribution. Also, we have to account for the fact that the intended delivery approach at some point needs to be used in the preclinical model, mostly in the non-human primates, the largest one. And finally, we have to take into consideration the volume which is injectable in the preclinical studies versus the volumetric scaling which is needed to progress from mice to non-human primates to human. So for that, mice is about 1% of the total ear volume of a human. A macaque is about 1/3 of the volume of the human. So an active dose in a non-human primate, you could multiply this by 3 to have an idea of the dose could be used in human. And across translational studies, we should use quantification of the transduction as a function of the dose in mice and non-human primate, and that should correlate. And sometimes it's difficult. Okay, and then so we are making lots of efforts to implement these methods for successful translation to mice to non-human primate to human. And for that, we need an injection system which is optimized. It needs to deliver the product uniformly across the target cells, across the full length of the cochlea. The injection needs to be minimally invasive, including surgery. We need a device to guide the positioning of the injection system through the injection site, the time of administration. Time of administration should be limited as much as possible, and the injection should be volume should be fixed and at a controlled delivery rate. We also think that the same volume and flow rate across individuals can be envisioned so far as the inner ear doesn't grow with age. We also need a well-tolerated surgical approach based on established otic surgeries. For the round window injection, we can use the method used by ENT for cochlear implant insertion in infants. And that's a good thing because infants are the primary population for the gene therapies I mentioned earlier. We can ameliorate exposure and limit gradients using double fenestration. So if we do that through the oval window, this is used by ENT for stapedotomy in cases of otosclerosis, and that's using a regular ENT laser. And if we do that through the lateral canal, it is currently less accessible and more invasive in human for fenestration. Okay, and now as a last slide, I would like to leave you with some paths to explore. First, optimize delivery. It is crucial to work out the microcatheter and the injection system for master delivery. It would be good to be able to inject through the wound window membrane, and there have been interesting progress with 3D printed microneedles. Also, recently, ultrasound-mediated microbubble cavitation has been also shown to facilitate AAV transduction across a wound window membrane, so that's interesting. Other interesting approach could be to further stimulate the distribution of the vector, like it was shown for steady streaming, generating an active propulsion of the drugs. We also should compose with inner ear fluids. So the perilymph composition is comparable to CSF. So AAV vectors are more generally formulated into saline buffers. It has been shown that saline buffers are well tolerated in non-human primates. But they also come with surfactants like puronic. Whether this can be ameliorated is an area of research, as well as formulating in artificial perilymph could be also of interest. And the last approach is ameliorate surgery. We use gels for internal sealing, glue for external sealing, plugs of muscle and tissue adhesive, clots for platinotomy, and mastering this aspect also is really of importance for the success of the gene therapy approach in the inner ear. And with that, I will stop and thank you for your listening and be happy to take any questions.
Yeah, thank you, Lon, for a comprehensive review of gene delivery techniques. And I hope others will start to put questions in the chat box. And we do have one here from Antoine Hoot. Which AAV would you recommend for targeting adult spiral ganglion neurons?
So that's the most difficult, actually, population to be targeted. There was recently a vector derived from AAV9 called AVS, which showed the good efficacy for that, but I'm not sure it was validated in adult neurons. So that would be a candidate. Okay,
great, thank you. And we have one last question from Ryosuke Yamamoto. Great talk. You said double fenestration has the risk of cochlear fluid replacement. Did you see any damage to the cochlear cells or auditory function via double fenestration approach?
No, we don't. We don't. Other groups have shown that you could even replace like more than 50% of the cochlear volume and be of therapeutic efficacy in preclinical models.
Okay, and Casey Jackson, last question. Hello, I was wondering if you had any experience with delivering a more viscous fluid to the inner ear, similar to the different formulations for transtympanic injections.
No, but that could be an area of research as well, because that would be less invasive and trying to administer NEV through the wound window via an optimized kind of gel, maybe could be something of interest, but I'm not sure it will go through the whole tonotopic axis afterwards.
Okay, wonderful. Thank you, Laurent. And with that, I'd like to introduce the last speaker of the day, Ronald Pennings from Rabdub University, who is a clinician scientist, a surgeon scientist, in fact, and he will be presenting on challenges in delivering novel therapeutics to the inner ear in humans. And the mic is yours, Ronald, and we can see your slides. Yes, it's in slide mode now. Thank you, Ron.
Well, thank you very much, Peter, for the kind introduction. I'm going to talk about inner ear, delivery of inner ear therapeutics to the inner ear in humans, which is a different cup of tea, comparing it to using inner ear therapy and researching it in animal models. So what are the indications for inner ear therapy? And I've put up some of these indications, and I think mainly sudden sensorineural hearing loss is one of the topics that has been addressed for over decades already by all kinds of different treatment modalities, but steroids is probably the most favorable one and widely used to treat sensorineural hearing loss. But others are there as well, like Meniere's disease, ototoxicity, noise-induced hearing loss, genetic hearing loss, tinnitus, autoimmune mediated hearing loss, and also the use of inner ear therapeutics to improve cochlear implant performance and to reduce the amount of damage that is being caused by the cochlear implant. But it's not very recent. I would like to refer to the paper that was written by Larry Lustig on the history of intratympanic drug therapy in otology. And I've looked into PubMed and searched for some early interventions. And we learned a lot from these studies that they did back in the old days. And I think that those interventions really helped us. But we are much more strict now when we're doing clinical trials to evaluate inner ear therapy. And I think inner ear therapy is booming. If you look at the number of publications and how much that is increasing every year, we are now up to 14,000. And I think this is really due to the fact that there is a big need for us to get better treatments to our patients who are hearing impaired. But as said, there are challenges for inner ear therapy delivery, and especially in humans. I think if we look at the field, it's rather unexperienced. There are few physicians, scientists who have experience with inner ear therapeutic clinical trials. There is a lack of inner ear specific biomarkers, molecularly as well as audiometrically, that also influences the outcomes of trials. And PK sampling is also quite difficult in human cochlea because you might disturb the delicate structures. And I think that there's also a need to share the knowledge that has been gathered through trials that have been performed. And I think data sharing on protocols of clinical trials are needed to educate the entire field. And this all has an impact on how the primary and secondary outcomes are defined in clinical trials. And to be honest, several clinical trials in humans have actually failed to show efficacy of novel drugs. And maybe that's also related to one of these factors here mentioned above. So if we then go to the classification delivery of inner ear therapeutics, then we can divide them into systemic and local delivery, as already was shown by Gael. And local delivery, you can divide these by post-auricular, intratympanic or transtympanic, and intracochlear or intralabyrinthine. And going from the left to the right, so going from systemic up to intracochlear delivery of inner ear therapeutics, the intracochlear concentration of the drug probably will increase, but the risk of damage will increase as well, which is tricky in humans. So when we zoom in on systemic delivery of in-ear therapeutics, then we are all aware of the oral and intravenous deliveries of, for example, steroids for patients who have a sudden deafness, but also patients who are suffering from labyrinthitis or meningitis or an otitis media will have benefit from antibiotics to treat the in-ear infection. It's usually non-invasive and therefore attractive, but we have the blood labyrinthine barrier. The blood labyrinthine barrier is very similar to the blood-brain barrier, and this is also one of the issues with the getting drugs into the labyrinth or into the brain. We're all aware of the patients who have an encephalitis or an abscess in the brain, that it's very difficult to treat that, and that antibiotics may take a long time to get into the brain before it cures the patient. And this has to deal with this barrier. This barrier consists of non-fenestrated capillaries with tight junction, and these tight junctions decrease the rate of entry into perilymph from blood by compounds of increasing molecular weight. So in the labyrinth, this function is mainly focusing on to maintain the ion homeostasis and to isolate the cochlea from the pathogens in the blood. So what about the post-auricular injection? And while I was preparing this lecture, Peter Steiger gave me this idea, and he said that he had seen it in the literature. So I looked for it, and post-auricular steroid injection is often used to treat sudden sensory neurohearing loss in China. And several studies have been published on that. Not too much, but there is some out there. A study by Leodal showed that on MRI imaging, a contrast was used in guinea pigs, and when they compared post-auricular delivery to intravenous delivery of the contrast, then they showed that there was a delayed time to peak enhancement and a prolonged elimination half-life, indicating that with post-auricular delivery, the amount of drug or contrast in this case into the cochlea was higher compared to intravenous delivery. And they also did a comparison, in another study, a comparison of post-auricular injection versus intratympanic injection of steroids, and they noticed no difference in outcome, which either indicates that post-auricular injection is indeed quite similar to intratympanic injection. However, it could also state that the steroids don't really do as much as we think it should be. And I think that this is interesting to further look into in the near future, and some trial protocols have been published already, so they're going to further evaluate. Going from post-auricular injections towards intratympanic delivery, and much has been said already about this. So there are non-surgical and surgical approaches. You can do a transtympanic injection, or either place a tympanostomy tube and then treat or inject the middle ear via the tube, or you can do a surgical procedure where you perform, for example, a middle ear inspection or an endoscopic ear surgery, so you get better access to the round window membrane or the oval window. And surgical procedures can also be used to place wicks, catheters, or micropumps. So when we're focusing on the intratympanic injections, it's important to realize that there is quite a variability in volume of the injections. So in our patients with sudden deafness that we treat in our outpatient clinic, it is noticeable that sometimes the volume of injected drug can vary a lot. And this may be related to the size of the middle ear, the volume of the middle ear. But Tang et al. Also showed that it might be beneficial to create an additional ventilation puncture in the tympanic membrane, a very small hole, to release the pressure, the building up of pressure, while injecting the drug into the middle ear. Another important thing that is that you have to realize when you're performing intratympanic injections is that in about 70% of the patients, that there is a round window membrane, pseudomembrane. And this is very familiar to cochlear implant surgeons, because we quite often need to remove that to get a good visualization of the round window membrane. But this also may obstruct the drug from entering the round window membrane itself. So it may be blocking the way of the entrance to the inner ear. And this may in fact be also one of the factors why sometimes steroid or gentamicin injections may be beneficial or not. And then finally, the optimal head position. I think a lot of research is needed. The study by Ungar et al. That I've shown here and the picture that is demonstrated here, after lots of calculations, they indicated that the optimal position would be to turn the head for 53 degrees away and to tilt it a little bit backwards while lying down. That would be the optimal position for the round window membrane to be in touch with the intratympanic, the injected drug. However, this is only based on one temporal bone, and I think that much more research is needed to see if there are actually differences in different positions, and not much research has been done on this so far. So what are then the advantages versus the side effects of intratympanic injections? Well, the advantage is, of course, that it has a limited systemic exposure compared to systemic injections. It's a simple, straightforward, and well-tolerated procedure, and this is something that you can do in your outpatient clinic. The disadvantage is that there will be a variability of intracochlear drug concentration, for example, limited by the pseudomembranes. And finally, you also need to talk about side effects when you're discussing this procedure with your patients, and you have to think about the related countermeasures. So these patients may experience vertigo, and so it may be helpful to warm the injected drug up to room temperature, so there's a less caloric effect. There may be, especially when you're performing repeated injections, a risk of tympanic membrane perforation, so it's fine to use a small needle, 25G or even higher up, so smaller in size, to prevent this from happening. And these patients may also experience a pressure sensation when you're injecting the drug into the middle ear. So a gentle flow rate may help, as well as an additional ventilation hole so that the air can leak out. And don't forget, obviously, to appropriately counsel your patients before you do this procedure so they are aware of what they have to expect. We performed a phase 1 clinical trial for AudioCure. And in that study, we've seen where we've injected their AC102 compound in the middle ear of normal hearing volunteers. We've seen a temporary conductive hearing loss. You see the slide up here with the thresholds going from the 250 up to the 8000 hertz. And especially in the higher frequency, you see a mass effect of the drug inside the middle ear that is influencing especially the higher frequencies and leading to a small conductive hearing loss for a couple of days. So it's only like 2 to 3, 4 days, and then this conductive loss was dissolved. And this is in line with what previously was said about the effect of the drug in the middle ear. And then finally, if we zoom in on intracochlear and intralabyrinthine deliveries, then these are always surgical. Round window insertion, oval window or stapledotomy, cochleostomy, cochlear implantation, granulostomy, and endolymphatic sac injection are all procedures that an otologist is capable of doing. But there is the advantages, of course, that you will get the highest intralabyrinthine or intracochlear concentration of the drug, and the disadvantages that you also have the highest risk of audiovestibular damage, because the mechanosensory tissues are very vulnerable to pressure changes and volume changes. So the fenestration technique has already been alluded to. And I think canalostomy is something that is quite easily done. If you're an experienced cholesteatoma surgeon, then you will know that you may have dehiscence of the lateral canal, which is quite easy to treat. And also patients with a superior semicircular canal dehiscence can be treated while finding the superior semicircular canal. And the advantage of using this fenestration has already been discussed by Laurent, where you can get much better access and much better injection into the entire cochlea. This has not yet been used in humans, but the problem, of course, after creating a third window in one of the canals is that you may have a third window phenomenon causing tulios, and this is something that you really should very tightly reconstruct when considering this kind of procedure in humans, and probably using the oval window and the round window as a double fenestration probably is a better option. So finally, I would like to zoom in a bit on several innovations that are currently is being worked on. So first, the first one is obviously cochlear implantation and the use of inner ear therapeutics. The advantage is that these patients all have a severe sensorineural hearing loss already, so the risk is smaller. And you can use drug-eluting electrodes with dexamethasone on the electrode to reduce the impact of the electrode, so to reduce the fibrosis that occurs around the electrode. But as also was shown in a first-in-human study by Athanasia Warnecke from the Harnover group, she used stromal cell-derived extracellular vesicles in order to perform hearing preservation surgery in humans. So there are interesting developments trying to reduce the impact of cochlear implantation on the delicate structures in the cochlea. Other innovations are the 3D printed microneedles. I'm referring to a paper from 2020 where these 3D microneedles were not hollow, but I saw a poster by the group of Anil Lalwani who showed that there are indeed hollow needles already available, and these would have an immense advantage because they may be useful for injecting small volumes of inner ear therapeutics into the inner ear, but you can also use them for perilymph sampling, and that could be useful for finding more biomarkers to better specify your clinical trials. And finally, the micropumps have already been mentioned as well. The advantage is that you can get an increased dynamic control flow rate and PK profile, refillable reservoirs, and all not yet being used, as far as I know, in humans. But applications could be to help protect the inner ear or to regenerate the inner ear, or you could combine them with cochlear implantation. So in conclusion, I think I've given you an overview of different delivery methods in humans. I think especially clinical trials, there are still a lot of challenges and uncertainties, and we need to educate the entire field to bring this further. We have a lack of biomarkers, molecular as well as audiometric, and up to now, it's probably difficult to control the delivery, especially in intratympanic injections of drug to the entire cochlea. We need more innovations for better control of this. With that, I would like to thank you all, and I'll give the word back to you, Peter.
Thank you, Ronald. That was a really great presentation. We do have a couple of questions. So the first one is from Caroline Coy. Thank you for your talk. How to do a fenestration on the oval window without affecting the stapes?
Yeah, so what you can use is a laser. You can use either a CO2 laser or a KTP laser, and that is something that we use in stapedotomy surgery for otosclerosis, and it's delicate, but it is possible to create a hole in the stapes and then afterwards seal it.
And so this kind of leads to my next question. So in the stapes, how would you seal it after use of the laser?
Yeah, so if we look at the at a normal stapedotomy, then we create a hole of 0.0 millimeters, and we place a piston of about 0.5 millimeters in diameter, and sometimes a vein is being used to fill that hole. But you can use probably some tissue, fibrous tissue that you can find either if from your incision, and if you don't make an incision, you can make a small incision in the earlobe and get some fat there, and place it on top of that and seal it off with some fibrin glue. that's something
Right.
that is doable. Yeah.
Right. And so, so the question that I had was, if someone did a channelostomy in the posterior semicircular canal, or whichever canal one was doing in a human, how would you seal off the hole so you don't get an effect, a side effect from that third window?
Yeah, that's an important thing. So what I usually do in cholesteatoma surgery is that I cover it first with a very thin sliced piece of cartilage from the pinna, and then I cover it with bone dust as an additional measure, and I'll mix that with fibrin glue to really tightly seal that off, and that should be enough to prevent tulio. But to be honest, this should be a one attempt type of surgery, because going back would be quite difficult, I think, and would have a risk of tearing all the structures when you have to remove that again. So it should be a single attempt surgery, and you should not want to go back again for this.
Fantastic. Thank you for sharing that. So we have a couple more questions here before we open up to the panel discussion. So the first is from Jonas Durfield Johnson. Very nice talk, Ronald. How much quantitative data have you seen on the actual effect of partial full pseudomembranes on perilymph drug exposure after transtympanic injection?
It's a very good question, Jonas. I don't have the answer, to be honest. But if I look at at my surgical experience as a cochlear implant surgeon, I know it's so often there, and it can be very thin, and then probably the drug may go around it and get access to the round window membrane, but it can sometimes be quite thick as well, and then it would really obstruct it. But I don't have any true data on that, to be honest.
Fascinating. And it would, if in a person with typical hearing, would that pseudo round window membrane have any effect on hearing?
No.
No.
No, you don't measure any difference. Yeah.
Right. Okay. Excellent. And so from Bonnie Jakes, as an MD, can you comment on how these different therapeutic strategies may be perceived by patients?
Yeah. Well, actually, that's one of the biggest questions that we have to ask. And we did that in a collaboration together with Vincent van Rompuy from Antwerp, where we asked patients with DFNA9 whether they would be interested in such a procedure. And in fact, because of the progressiveness of their disease, leading to finally profound hearing loss and vestibular areflexia, they definitely would go for that. But it also depends on the type of the disease and how much it affects these patients. So I think this is a very important question that we should ask our patients, and to further zoom in to find out whether they are actually really looking for these kind of interventions. I think it also depends on how promising novel therapies will be. And if you would have to come in every month for an injection in your ear, well, that's probably patients will be less enthusiastic than when it's once a year or when it's a one-time surgery. Yeah. So I think these are questions that we need to ask our patients. Yeah.
Fantastic. So with that, thank you, Ronald. This was a great closure to the formal stage of this session, and I would like to open it up questions to all the panel, the speakers from the audience, and perhaps we can have an extended discussion, possibly via me and Rami presenting questions that come up in the chat. But as people compose their questions in the chat box, I'd like to ask Rami to, I know I'm putting him on the spot here, but to just give some immediate reaction to the presentations that he's heard so far.
I thought it was that we got a tour de force from Gael about the preclinical models. We had very nice, overview from Bonnie about the not only the clinical experience and how the reformulation of drugs can improve the pharmacokinetics, but also how this correlates between the preclinical experience and the clinical experience. And again, a tour de force from Lorraine about the preclinical models of gene delivery. Finally, with Ronald, it was very interesting to hear, how this area that is burgeoning and growing experiences, clinical challenges in adoption. And there are many clinical challenges. And I really have a question for you, Ronald. It's always interesting for me to, to hear from clinicians in these situations where there are clinical challenges. Are there, preclinical studies that need to be, from your learnings, from what you see, what are the challenges? Going back into animal models, are there questions that need to be studied? Are there new models that need to be developed in order to help you answer questions or develop better clinical methods?
Well, a good question, Rami. I think from a clinical trial perspective, and that's not really related to the models, but I think, as I already mentioned, I think the biomarkers, I think the cochlea is still a black box. We are treating lots of patients based on mainly a pure tone audiogram or a speech audiogram, whereas what is occurring on a molecular level in patients is so different between subjects. And so I think if we get to know more from that point of view, learn from the molecular biologists that are evaluating the impact of different genes in the inner ear, and better being able to get a true deep phenotype of hearing loss, and not just like a crude audiogram, but much more detailed. I think that would really help us to get better clinical trials, and to better select the subjects for the clinical trials that are being performed. I think that's one of the things that pops into my mind on your question.
Yeah, so that's interesting. One thing that popped into my mind, and I don't know if people have studied this, but you mentioned the challenge of sampling in the inner ear in humans clinically. And one approach that could be used is to correlate, preclinical standard, well-controlled preclinical techniques for sampling versus those that are translatable, and seeing what the limitations are, and is there a way to somehow predict what the variability, what the errors are, how important they are. That's one type of study that seems interesting.
I absolutely agree with you. Yeah.
So this kind of segues into a question that's come in through the chat box from Casey Jackson. She really loves all the talks, and she would really like to hear comments to this question from all the panelists. Due to the differences in anatomy and likely perilymphatic flow rate and size and head positioning differences, how necessary is it that the animal administration match exactly or closely to the human administration? And that's to all the panelists.
Yeah, I can take a stab at that first. I think we've got a lot of experience kind of looking at both the clinic and animal models. And in our experience, I think if you're getting close, I think that's sufficient. I don't think you need to match it exactly, because we have to remember, if we take, say, rodent, for example, their temporal bones are positioned differently. They have different thicknesses in bone. And so you're going to get different diffusion kinetics possibly into the cochlea, say if you're using an intratympanic delivery method versus the human that is much denser bone. You're looking at a very minimal kind of round window area. And so I think, if you're using a good enough model, I think that's sufficient. And it doesn't have to match exactly, because we know that there's going to be limitations and constraints from any animal species that we use in terms of size of the external canal, say to even access the round window. In rats, for example, a transtympanic injection is a blind. is a blind delivery. And so our surgeons train for many months using dyes to land the drug at just the right spot. So there's no way you're going to mimic that exactly in humans. But I think kind of thinking about the volume of the drug and the concentration of your drug relative to the body size of your target animal or your model animal, I think is important when you're trying to then translate that information to the humans.
Comments from others?
Gail, maybe you can speak to
Sorry.
that and also in general address the question of, how do you choose the species?
Yeah, so it's true that there is, in animal models, there is several differences in anatomy of the temporal bone and in the middle ear itself. So all the technique I have shown cannot be performed in all species. For example, we are not able to perform any PSCC injection in the guinea pigs or in the rat due to bone densification. And in fact, as mentioned by Bonnie before, we select the species accordingly to the efficacy study we want to perform after that, because we have different models in different species, and not all species are adapted for all models. And again, as Bonnie explained, we have also trained our team member, our surgeon, to perform exactly the transtympanic injection at the right place. For example, between the rat and the guinea pig, it is not exactly the wall on the eardrum is not exactly at the same place. So there is a lot of differences in technical differences and anatomical differences between animal species and also with human. In this case, we need to be to do our best with each species to have the best model for each species, and it cannot be it cannot match exactly the human.
So Laurent, if I could just jump to you, did you find major differences between using rodents and non-human primates?
Yeah, yes, for sure. We don't use a double fenestration in mice, for example, because we focus more on the proof of concept data, proof of efficacy, and then we use more the non-human primate to be a closer situation to the human. But even that, as mentioned by the others, we have the route of access, which is different. The surgical access, initial surgery is different between monkeys and humans. So we try to be as close as possible, knowing these limitations.
Thank you, Laurent. And Ronald, did you find any? How's your response to this question? Coming from the human clinical perspective, how important is it that the preclinical studies match the human implementation of such a drug delivery?
Well, I think you want it as close as possible, of course, but I also think that we, with the treatment deliveries, how we do it in humans, there is still so much variation and still a lot unknown about, for example, intratympanic injections, as I mentioned, that's something that we should study as well. So, but I think you should have it as closely as possible. Yeah, because that's also the safest for the patient when you're trying it first in human.
Okay, fantastic. So we're coming up to the top of the hour, and I would like to thank everybody for being here. And I do have one announcement I would like to make, and that is that in a few, hold on a second, I need to share my screen, and that is in June. I will be, can everyone see my cursor?
Now we do.
Yes, okay, great. So on the Friday, the 3rd of June, Creighton University will be holding its 4th annual Bellucci Symposium on hearing research, and we're going to be focusing on age and age-related hearing loss. And we have 10 speakers, and we will have a couple of prize winners giving keynote speeches and talks about their research. And so for those of you who are interested in learning more about age-related hearing loss and translational approaches, I'm very pleased to announce this. And if you want more information, do email me. And for those of you that are already on our Bellucci Symposium mailing list, we'll be sending out a save the date card in short order. So with that, I want to thank everybody for attending and being with us for 2 hours this morning. I want to thank all the speakers who have presented phenomenal presentations. And as Christina from ARO and management team, the video of this will be shown, be streamed for the next 2 weeks once they have edited for clarity. And so we can all get a chance to view these slides and presentations again. Again, I want to thank the speakers for their fantastic presentations and their insights and sharing with us their expertise, and also for Rami for providing an outside assessment of what we're doing here in ear therapy. And we are getting a lot of thanks through the chat box. So thank you very much, everyone. And hopefully we will be meeting again in person real soon. With best wishes, bye-bye.